Well, good morning, everybody. Thank you so much for coming up on this beautiful morning. Roads are clear, sun is out. Going to be a better day to commute to this presentation than today, right? So in respect of everybody's time, I think we're going to get started here. Before I start in the topic, I just want to give you some background about non-atherosclerotic abdominal vasculopathies. Since my training, oops, I don't know what's happening there. Do you know what's going on? So in any rate, since my training was at Mayo, when you start training at Mayo, they tell you that you're going to see more zebras than horses, and that's exactly what was happening there. So I saw a lot of patients with abdominal or intra-abdominal vascular dissections, aneurysms, pseudoaneurysms, and one time you make a diagnosis of FMD, the other time you make it as a SAM or segmental arterial mediolysis. And said, no, this is vasculitis. I got really impressed or interested in this topic because a lot of, not a whole lot of data out there to help with differential diagnosis. And since 2010, we have probably more than 10 publications in this kind of topic. We're proud to be authors on the largest case series for non-atherosclerotic abdominal vasculopathies, including FMD and SAM, and we go over these publications as we move forward. So, disclosures, not a whole lot related to this topic. So what we're going to cover today, we're going to cover different non-atherosclerotic abdominal vasculopathies, including FMD, SAM, and so forth. And first, we're going to go over some case presentations, and after which we're going to cover underlying etiologies, including FMD, segmental arterial mediolysis, connective tissue disorders. We're going to provide some tool to help with the differential diagnosis, which could be very difficult. And we're also going to summarize management plan and outcome. And again, we're going to share our experience. As I said, we actually author the largest case series in the literature. So what is the problem that we're going to cover? We're going to, as I said, we're going to cover all these mesenteric and all renal artery dissections, aneurysms, stenosis or thrombosis, vasculitis. We're going to talk about the epidemiology. As you see from the slide, these are very rare diseases and with very scarce literature. And the presentation with these patients, they can, sometimes you find these aneurysms, dissections incidentally, but also some patients come with life-threatening intra-abdominal bleed or hemorrhage. So in terms of diagnosis management, there is no really good consensus for diagnostic process. And sometimes it's very hard to make differential diagnosis between FMD, SAM. When I work with my physician assistant team, okay, so we scratch our head, FMD, SAM, vasculitis. And then management can be very challenging, and outcome could be, very benign like FMD. It could be a life-threatening like Ehlers-Danlos and vasculitis as well, too. So the etiologies we're going to be covering today, we're going to cover fibromuscular dysplasia, segmental arterial mediolysis or SAM, connective tissue disorders, including vascular EDS, Loeys-Dietz Syndrome, that we started to see more publications in that regard, Marfan's, localized vasculitis of gastrointestinal tract. Not a whole lot of literature on that. The most kind of the literature we see from Ken Warrington, he's a rheumatologist at Mayo. Median Arcuate ligament syndrome, which I have a specific interest in. Trauma-isolated disease, like sometimes we see just a dissection in one vessel. We call that isolated dissection or isolated aneurysm if it affects only one vessel. So I think we're going to start with some cases. My goal in presenting first 7 cases to show that or emphasize the fact that most of these cases have similar presentation. Most of them will come down with abdominal pain, nausea, vomiting, and sometimes diarrhea. And they're going to have really common CTA or imaging findings, but the differential diagnosis could be a little bit tricky. So the first case that we're going to cover today, it's actually a case of ours, 74-year-old female, history of coronary artery disease. Many years ago, she had also uncontrolled hypertension. She comes down with abdominal and neck pain, like all other cases that we're going to see. And family history is important. That she has 3 sisters. She told me, I have 3 sisters, and my daughter, we're told that they have some vasculopathies or irregular vessels, and she couldn't give me more information. Blood pressure on presentation, 160/90, slightly elevated, pulse is fine. Exam finding, she had a right side carotid bruit and mild epigastric tenderness. ESR and CRP slightly elevated. We're going to see this in most of the cases. We're going to question the role of checking ESR and CRP all the time because most of these labs will be elevated in acute presentation. So this is a CT angiogram image of this patient when she presented. On the left side here, this is a transverse image showing a dissection on the celiac artery with pseudoaneurysm right there. And we also appreciate on the coronal view, trying to move that cursor right here. So there's a tortuosity of the aorta right there, and also the left renal artery. There are some irregularity at beating appearance as well too. And this is a CT because she came down with neck pain as well. This is a CT angiogram image of the neck. On the far left here, you appreciate that this is a transverse image showing a dissection of the left vertebral artery right here. This cursor is going to be a little bit tricky, but you can appreciate the arrow there. And the one in the middle, you see also a dissection on the left vertebral artery. And the far right there, you see actually you appreciate a tortuosity of the right anterior carotid artery with some beating appearance as well too. So question for you, is this an FMD, but the patient has family history of 3 sisters and 1 daughter? Or this is the segmental arterial mediolysis because there were some dissections, right? And FMD, not very often that comes down with a dissection. Is this a vascular Ehlers-Danlos syndrome because she has multiple vasculopathies? Or this is a LDS or Loeys-Dietz syndrome? Or this is a type of vasculitis? So this is the question. And actually, the diagnosis is fibromuscular dysplasia because, as you see from the case presentation, she does meet actually the most recently updated definition of fibromuscular dysplasia. Focal or multifocal FMD lesions, like beating appearance in a multifocal, or focal, you see really a focal stenosis, plus other vasculopathies, aneurysm, dissection affecting mostly the renal artery, but it can affect any vessel in the vasculature here. So also, age and gender of this patient, she's a female, kind of young adult. She has beating appearance, right? And as a matter of fact, remember I said she had a remote history of MI. So the patient had actually a history of SCAD. I know that we had this presentation a few weeks ago here. She did not have any significant wall thickening or elevated ESR or CRP, slightly elevated, not significant. And genetic testing, because she had multiple vascular involvement, I did actually send for genetic testing, came back negative. It's less likely segmental arterial mediolysis, although biopsy was not feasible in this lady. So the management actually was aspirin, good blood pressure control, and imaging surveillance, and she's still doing well. Now, the next case, 47-year-old gentleman, no significant past medical history, presented again with neck pain, headache, followed by abdominal pain. So family history this time, no significant family history in terms of vasculopathies. Blood pressure, again, on the higher side, pulse on the higher side. He did have some neck and abdominal pain. ESR and CRP, again, slightly elevated. These are CT angiogram images of the abdomen pelvis. If you look at the panel A here, you see dissection involving the SMA right over here with pseudoaneurysm. And this is actually an aneurysm involving the splenic artery. You also appreciate right here, you see actually actually splenic infarct and right renal infarct right over here. On the panel B, you see hepatic artery irregularity and possible dissection with intramural hematoma. And panel D right here, you see that there's a distal SMA dissection right there. And on the panel, actually D right there, trying to show that, right renal artery dissection, which could have caused that renal infarct on the right side. So multiple vasculopathy, and because the patient had the neck pain, we also scanned, actually this is still going for the abdomen. So also you see a distal, actually an ileocholic branch here. There's an aneurysm with some kind of surrounding intramural hematoma, and the patient has significant intra-abdominal hematoma as well too. So this is the CT angiogram images of the neck and brain. On the far right, panel A, you see really right internal carotid artery dissection with intramural hematoma. That same internal carotid artery dissection in the oblique view here, you can see appreciate the significant stenosis caused by that dissection with intramural hematoma. And the far left here, you see also left internal carotid artery dissection where the arrow is showing on the far right side there. So patient, again, young man, multiple vasculopathies, intra-abdominal hematoma. Is this FMD? He's not female. It's a very dramatic presentation. Is this segmental arterial mediolysis? Possibly, right? He's a guy, multiple vasculopathies, including mesenteric vessel dissections. Is this vascular Ehlers-Danlos? Also possible. He's young. He's got multiple vasculopathies. Or is this Loeys-Dietz syndrome or vasculitis? So technically, he actually meets the criteria, or the most commonly used criteria for segmental arterial mediolysis, which is dissection or aneurysm with or without infarction of multiple mesenteric vessels. And I put multiple in italic there because our definition for SAM, the patient has to have multiple vascular involvement to call them SAM, and with exclusion of FMD or other vasculopathies like connective tissue disorders. So the biopsy of that patient, because he underwent, as you're going to see here shortly, he underwent laparotomy, and the biopsy confirmed the common finding with SAM, which is lysis of the outer arterial media leading to dissection and pseudo aneurysm. Plus the patient age, kind of consistent, and gender, dramatic presentation, not like with FMD. Usually FMD is incidental or mild pain. Genetic testing, actually, we ended up testing for genetic disorders and came back negative. The patient did not have significant wall thickening apart from that intramural hematoma, and ESR and CRP were slightly elevated. So the patient was managed with hematoma evacuation, blood pressure control, aspirin, and imaging surveillance. So case 3, another younger male, 38-year-old guy, history of tobacco abuse, no relevant past family history. I think that's important to realize there. Presentation, again, he came down with abdominal pain, nausea, vomiting. Blood pressure was slightly elevated, pulse not bad. He also, exam showed generalized abdominal tenderness, ESR and CRP, again, slightly elevated. So CT angiogram image, you could appreciate from the left upper right there. There is actually a celiac artery, pseudoaneurysm, and maybe aneurysm, and there's possible dissection, and you see there's significant irregularity right there. And then on this panel right here on the right upper, you see a right renal artery dissection. On the left lower, you see a common iliac artery aneurysm, as you see on the arrow. And right here, you see a dissection of the left common iliac artery with thrombosed false lumen right here. So, so diagnosis: FMD, SAM, vascular Ehlers-Danlos, Loeys-Dietz syndrome, vasculitis, and actually this patient we diagnosed with vascular Ehlers-Danlos because his genetic testing actually showed some variant of collagen 3A. We actually ended up publishing this case because this is a novel frame shift of that gene that has not been prescribed in the literature in the past. And the patient does meet the criteria because he has one major criteria of rupture vessel plus positive genetic testing. And again, the patient is young, 38, multiple arterial involvement, but no significant markers elevation, slightly elevated, no suggestive family history, because we always kind of rely on family history when we look at vascular Ehlers-Danlos. As a matter of fact, 60% of these cases do not come down with family history because they are usually de novo mutations. And also, we always ask about, okay, do you have hypermobility? Do you have problem in your skin? And actually, most of these patients do not have these concurrent musculoskeletal symptoms. So the management was with aspirin, blood pressure control, imaging surveillance. And now there are a lot of studies that recently published on celiprolol, which is a beta antagonist, beta 2 agonist. And actually, it unfortunately did not receive FDA approval. It was on the table last June, and has been shown to reduce complications with vascular Ehlers-Danlos syndrome. So this patient, actually, we prescribed the drug for him, and he's getting it from Canada at this point, fortunately. The fourth case, 50-year-old female, again, past medical history, obesity, hypertension, tobacco abuse, no relevant family history, abdominal pain. That was the presentation when she came in. Blood pressure on the higher side. She came down with severe epigastric tenderness. ESR is 48, CRP is on a higher side. So you see more of elevation of these ESR and CRP in this case in particular. CT angiogram images, again, on the left side is a transverse CT angiogram image showing a significant wall thickening of the celiac artery right here where the red arrow is, right here, significant wall thickening. And if you look at the sagittal view, actually confirming that a significant wall thickening involving the celiac artery in this patient. Okay, is this FMD? She's female, could be, right? But I don't see any bleeding. I don't see any really dissection, clear dissection. Is this SAM? Not sure. Vascular Ehlers-Danlos, LDS, or vasculitis. So, so actually, she does meet the commonly used criteria for localized or isolated vasculitis of gastrointestinal tract because there's significant wall thickening involving the celiac artery. No other pathologies found, no bleeding, no dissections that we found. And the condition, her condition actually worsened. We first put her on aspirin. We waited for about 3 weeks, and the patient came back and actually had to come back before the 4 weeks mark, which I usually bring them back. She came back earlier saying, oh, Dr. Skeik, I still have significant abdominal pain. I repeated images, and her wall thickening actually got worse. And so what we did, we thought about, okay, so this possibly isolated vasculitis of the gastrointestinal tract because she had no other symptoms, and we started her on prednisone with significant improvement of her symptoms and imaging findings. So I have to emphasize the fact she had no rheumatological symptoms. That's why we call it isolated, right? And autoimmune workup was negative for rheumatoid, lupus, and other, etc. And she had a negative testing, genetic testing, no other arteriopathies, and her tissue biopsy was not feasible to kind of look for other pathologies. So her management was prednisone taper, aspirin, imaging, surveillance. So case 5, 63-year-old guy, history of aortic, bicuspid aortic valve that went in a significant regurgitation, received St. Jude mechanical valve, diabetes mellitus, hypertension, hypolipidemia, was on warfarin for a longer time. He came down again with abdominal pain and nausea, like all other cases. And family history not relevant, blood pressure on the higher side, and the physical exam, you appreciate the mechanical second heart sound. No murmur, though, that you think about vegetation or anything like that, or failure of that valve. And again, he had a significant abdominal tenderness. White blood cell count, pretty high, 23,000. Hemoglobin on the higher side, platelets on the higher side. Over 2 years, the INR has been really well therapeutic over time for St. Jude valve, 2.1 to 4.4 for 2 years, which is kind of rare that you find this. And so the CT angiogram imaging, transverse images, you should actually appreciate that there is a celiac artery thrombosis or thrombus within the celiac artery lumen, and actually that extended to the hepatic artery on right here. It's very hard to show. I'm sorry to kind of put the cursor where you want it to be. And then over here you see the aortic. There is some aortic thrombus with right renal that comes into the right renal artery, and also here you see a thrombus in the left internal iliac artery as well too. So what's up with this patient? Is this antiphospholipid syndrome? Is this HIT, essential thrombocythemia, malignancy, aortic vegetation? So could be any of these, right? So technically, so he actually meets the criteria for essential thrombocythemia because remember his platelet count was elevated, positive JAK2 mutation. Actually, if you have a patient that thrombose despite the fact that they are on therapeutic warfarin, you have to think about myeloproliferative disorder or malignancy, right? And we've seen it here in our practice. So he actually had positive JAK2 mutation and elevated platelet count, which we saw earlier. He had unremarkable TEE. There was no vegetation, no valvular problem, or other malignancies where workup was negative for other malignancy, and no recent heparin exposure to think about HIT, negative antiphospholipid syndrome workup. So management, we added aspirin, continued on warfarin, and we sent to hematologists who started hydroxyurea with a resolution of the thrombi based on the repeat image. So last couple of cases, case 6 here, so 51-year-old female, no past medical history, came down with epigastric abdominal pain, with nausea, especially postprandial abdominal pain, and she lost about 20 pounds in the past year before presentation. And she had no relevant family history. Vital signs are normal. And when you examine her, she had epigastric tenderness with epigastric bruit with expiration, and her labs were fine for lipase and CBC and CMP LFT. This is a sagittal view of her CT angiogram image showing significant stenosis of the proximal celiac artery with post-stenotic dilation. And so what do you think this is? This is actually straightforward. This is a median arcuate ligament syndrome. She comes down with typical symptoms of postprandial abdominal pain, imaging showing that median arcuate ligament compressing over that celiac artery in the proximal segment with post-stenotic dilation. And there was no other explanation for her symptoms. To make the diagnosis of median arcuate ligament, you have to really rule out other pathologists. So negative workup, EGD, colonoscopies, and etc. Management, she had ganglion block, splanchnic ganglion block, and she had good response. So she had median arcuate ligament release and went on aspirin. Her symptoms improved. So that comes down to which is which, right? All of these patients come down with epigastric or abdominal pain, right? And you do these CT angiogram images. They all kind of have different, kind of similar findings of mesenteric and or renal artery dissections, aneurysms, or pseudoaneurysms. So that actually got my interest to kind of grow up over years. And we actually, with the help of MHIF and the research interns, we actually ran a case study in our population between 2000 and 2015, looking at all patients that presented with abdominal vasculopathies, the age between 18 and 60. Pathologies that we were looking at were arterial stenosis, wall thickening, dissection, aneurysms, pseudoaneurysms, and affecting only renal, celiac, hepatic, splenic, and mesenteric arteries. And so, we actually, not we, but I would say the research intern, thanks for them, they actually reviewed 1,400 charts over the summertime around 2015. I think Jonathan was there at that time. And we excluded quite a few pathologists because it was very hard to really come down to pick up just the vasculopathies because these patients come down with other pathologies. We actually included 118 patients. And what we did for data collections, we looked at demographics, comorbidities. Of course, I think it's important to look to see if does diabetes has anything to do with this, hypertension, tobacco abuse. Right, presenting symptoms also. We looked at physical exam, medications, and laboratory data and diagnostic images. So the diagnosis that we used, most commonly used diagnostic criteria based on consensus guidelines or Society of Vascular Medicine, Society of Vascular Surgery, expert opinion. Some of these diagnoses were presumed because not all of these cases, because it is a retrospective analysis, not all these patients had tissue biopsy or genetic testing. So some of these diagnoses were presumed. So FMD, you guys know FMD very well. So it's a non-atherosclerotic arterial disease with abnormal cellular proliferation. There are two different types. It's multifocal that you can see beading appearance on the CT angiogram, or it could be just a focal type of FMD, which you see a focal stenotic lesion, mostly affecting renal artery, but it can actually affect any vessel. And patients can present with beading appearance, dissection, aneurysms, or tortuosity. Actually, as a matter of fact, now we see a lot of tortuosity in patients with FMD, as this has been reported and very well focused on. And so 90% of these patients are female. The definition that we used, which is consistent with the recent update from the international consensus on FMD diagnosis, is stenosis, occlusion, dissection, or aneurysm in renal or extrarenal arteries, especially also the most commonly affected vessels could be cerebrovascular as well, with concurrent string of beads if it's a multifactorial or a critical focal stenosis, right? That can be affecting any vessels, excluding the aorta and excluding other vasculopathies. So segmental arterial mediolysis, when we define that, what is it that's segmental arterial mediolysis? Some people believe that segmental arterial mediolysis is actually the end of the spectrum of FMD. But actually, this has been proven that they are totally, completely different pathologies. Again, it's a non-atherosclerotic, non-inflammatory vasculopathy. It's characterized by vacuolar degeneration or lysis of the medial layer that leads to dissection and or aneurysm and pseudoaneurysm, mostly affecting the mesenteric vessels rather than the renal or cerebrovascular. But again, it can affect any vessel, mostly mesenteric. It could affect renals. We've seen it in our patient. It can affect the cerebrovascular as well too. And mostly or slightly more common in males, as we're going to see in our second publication or second project that I'm going to present to you. So the diagnostic criteria that we used, again, dissection and aneurysm affecting the mesenteric vessels, whether that with or without infarct, with exclusion of other vasculopathies. How did we define localized vasculitis of the gastrointestinal tract? It has to be a localized vasculitis. You can't have generalized or systemic vasculitis in these cases. So the most commonly finding that we see in these patients is significant wall thickening of that affected vessels, with or without, aneurysms, occlusion, dissections. And you have to have imaging, positive imaging, with or without pathologists, because not always you can get pathologists in these patients because it's not feasible to go down and biopsy the arteries. And again, the diagnostic criteria we use, you have to have GI manifestation. If you can't have histopathological evidence, angiographic evidence of that, then you need that angiographic evidence of significant wall thickening, plus minus aneurysms, dissections. And inflammatory markers, again, can be elevated or normal. Not always in isolated gastrointestinal vasculitis that you will see elevated inflammatory markers. So Ehlers-Danlos, as you guys know, it's a life-threatening arteriopathy that caused by the mutation or alteration of the collagen 3A gene that can lead to significant ruptures or arterial aneurysms, dissections, which is part of the major criteria. And as you know, major criteria, besides the arterial rupture, patients can present with rupture of some internal organ, including uterine and intestinal. Minor criteria, some different musculoskeletal findings. So you have to have two major criteria to kind of think about that diagnosis. If you have two minor criteria, you have to have a positive collagen genetic mutation. And so the diagnostic criteria we use is positive Villefranche criteria, which is the criteria I just mentioned up, plus the positive genetic testing. So how did we define the Loeys-Dietz syndrome? As you guys know, that's kind of more publication has been coming out regarding Loeys-Dietz syndrome. It's an autosomal dominant syndrome that leads to especially aortic aneurysms, more than really branches of the aorta. But again, those patients can come down with systemic involvement, including cardiovascular, craniofacial, skeletal, cutaneous manifestations. So, so to consider diagnosis, the patient has to have those kind of musculoskeletal or skin manifestation plus vascular aneurysms, dissections. To confirm the diagnosis, you test for 5 genes. I'm not going to go over the details. And the most commonly gene that's kind of related to arterial abnormalities is mutation of the SMAD3 group that lead to kind of weak collagen, and then hence the aneurysms and dissections. So the diagnostic criteria have to have a phenotype and genotype positive to be included. We kind of cover the diagnostic criteria that we use for median arcuate ligament syndrome, which is compression by the median arcuate ligament over the celiac artery, leading to significant proximal stenosis with dilated distal artery. And it's usually a diagnosis of exclusion because you have to really exclude other pathologies like gastroenteritis, gallstones, other arteriopathy to kind of say, well, this is median arcuate ligament syndrome, because about 15 to 20%, actually about 15% in one series that you see, if you scan everybody, you see there is kind of a finding of median arcuate ligament compression. And so, so this is the diagnostic criteria that we use for median arcuate ligament. So these are our results, kind of. I think it's important to appreciate that we had 118 patients, so about 30 patients, if you look up here in the first kind of box, FMD 30 patients, isolated aneurysm about 29 patients, median arcuate ligament 18 patients, and so forth. What you can appreciate from here, this is a kind of busy table, but these patients are younger patients, younger adults, around their 50s, right? But if you come to Takayasu arteritis, these patients could be younger in their 30s. And then EDS, 40s. And so, they are younger adults. And there is a predominance in females. If you see FMD, because most of these cases, like 30 cases out of the 118 were females. So you see more, if you look at all patients, most commonly actually females, right here. These are males, 35%. And so an exception of actually trauma, SAM, EDS, those patients were kind of more males than females. Common comorbidities we've seen hypertension. About 52% of these patients had hypertension. We are not sure if this is kind of cause-effect kind of correlation, or it's just we find more hypertensive patients. Tobacco abuse is actually prevalent. About 43% of these patients had history of smoking or actively smoking at the time of presentation. So what kind of arteriopathy that we found? Most commonly that we found was aneurysm. About 60% of the cases had aneurysm. Stenosis, about 40%. Dissections, thrombosis, and renal infarct, the rest. And you can see that localized vasculitis of gastrointestinal tract, they have actually mostly stenosis because of that wall thickening that we mentioned earlier. And segmental arterial mediolysis, their kind of patients had aneurysm. All of the patients had aneurysm. 80% had stenosis. 60% had actually dissection. And we're going to actually talk more about segmental arterial mediolysis in the second project here. So the arterial involvement, the most commonly artery that was involved was the renal artery. And again, FMD comprised most of these patients. As you see, 30 patients out of those 118 patients. That's why we see more renal artery involvement. The next would be celiac artery, about 36% over here. And splenic artery, about 26% SMA, and hepatic, and the least that was involved was IMA. Isolated aneurysm, actually more commonly seen in the splenic artery, which we see quite a few actually isolated aneurysm in the splenic artery. And the commonly artery that affected by localized vasculitis of gastrointestinal tract was the SMA, as you see there. And SAM, we had the most commonly artery that was affected was celiac, followed by SMA. And again, we're going to focus on SAM in the coming slides. Again, this is kind of consistent with the cases that I presented earlier. Elevated ESR, from those patients that had ESR checked and those patients that had CRP checked, most of these patients actually had markers elevation, because when you test for ESR and CRP in acutely presenting patients, you're going to find elevated markers in these patients. So kind of question the role of these in this setting. CT angiogram images were actually the most commonly used imaging technique, followed by MRA and Doppler ultrasound. So the most commonly presenting symptom in these patients was abdominal pain, followed by nausea, diarrhea, and about 32%, actually 26% of these patients were asymptomatic. We're going to see actually more symptomatic patients when we focus on SAM patients. But again, these patients had, quite a few of these patients had FMD, so not always these patients will be symptomatic. So 26% of these patients could be asymptomatic. And also we had quite a few median Arcuate ligament syndrome as well too. So most of these patients actually were treated conservatively with just blood pressure control, aspirin. But about 14% of these patients actually received colembolization. About 12% had angioplasty. Some of these patients were FMD. And about 10% had open resection or surgical revascularization. And again, some patients received prednisone. And for those patients with median Arcuate ligament syndrome, had some release, either open or laparoscopically. The outcomes, I think it's important to realize from our series that about 92% of these patients actually had relief of their symptoms by the end of the study. About 14% of these patients had symptom recurrence. And from those patients that had imaging, about 30% of these patients had improvement of their images. Unchanged, about 30% too. You're going to ask me, why didn't these patients improve? Because if you have bleeding, you're going to continue to have bleeding. If you have aneurysm, you're going to continue to have aneurysm. So we didn't really see significant percent of these patients had improved of their imaging findings. So in summary, 118 patients that we followed in our series. Median age about 47, mostly females. Common comorbidities were hypertension and tobacco abuse. And we listed kind of different diagnoses that we diagnosed. And most commonly pathologies were aneurysm, stenosis, followed by dissection and thrombosis. And renal artery, celiac artery, splenic were common. Imaging, we actually saw more use of CT angiogram images than other modalities. And again, ESR and CRP, for the most part, were elevated in most of these patients. And I think, the role of genetic testing in pathology comes really sound, especially in patients with multiple visceral involvement and beating appearance that you're not sure this is SAM, FMD, or vascular Ehlers-Danlos syndrome. So we started sending a lot of patients to Alison Berg here. We for genetic counseling, and she's been very helpful to kind of address these concerns. Symptoms, don't focus on this guy sitting on the toilet right here. But common symptoms that we saw is including abdominal pain, about 55% of the patients, nausea, vomiting, and so forth. Actually, management, again, about 33% of these patients had actually conservative management right here. But again, we saw more of endovascular procedures that perform rather than open procedures to address the problem if it occurs. The good news, about 91% to 92% of these patients, the majority of these patients had symptom improvement, and those patients that had images, about 30% of these patients had improvement. So after this project, I wasn't satisfied, because I want to know, how do I diagnose SAM? How do we differentiate SAM from FMD? Because again, there are a lot of unanswered questions. So we did another actual literature review that looked at specifically at SAM patients. As a matter of fact, this was just published, and it's the largest case series in the literature for segmental arterial mediolysis. So we had reviewed 66 reports, came down with 126 patients, and we included 17 patients from our institution, and papers that we really selected to be included, those papers that included demographics, because we want to extrapolate data from there, and also arterial involvement and arteriopathy, if they reported what kind of artery, what kind of involvement they had, and if they reported the diagnostic strategy. That's how we included the paper, because we want to get some information to help us figure out what SAM is. So SAM what's our definition for SAM is similar to what I just had presented earlier. Different authors, though, use different criteria. But for the most part, Mayo and us and some other major centers use the same criteria here. You have to have multiple mesenteric vessels involvement, not just single arterial involvement. But again, different authors from different papers use different diagnostic criteria. If you have a diagnostic tissue diagnosis, you have to have a vacuolar degeneration or lysis of the medial layer leading to dissection aneurysms. Differential diagnosis, we did the same way that we did in the previous paper, kind of defining other differential diagnosis. So for demographics, actually, again, these patients are younger adults, like the median age is 55, mostly males, right? The other paper was mostly females, because we had quite a few chunk of these patients had FMD. So 67% of these patients were males. Hypertension, again, it's another concurrent comorbidity or prevalent comorbidities, like 42% had hypertension. Tobacco abuse, another really, about 12% of these patients had tobacco abuse. The question, does hypertension is kind of a cause-effect kind of correlation? We don't know, okay? But we tend to kind of try to control hypertension in these patients very importantly. So how did these patients present it? So this time, because it's a SAM, right, most of these patients came down with symptoms. So abdominal pain, 80%. Actually, intra-abdominal bleed, look at the second box here, about 50% of these patients came down with intra-abdominal bleed. So most of these patients came down with symptoms. Nausea, vomiting. As a matter of fact, about 4% of these patients came down with a shock, which is kind of significant. If you look at vital signs, some patients came down with high blood pressure, like our patient, but some patients came shocky with low blood pressure. Low hemoglobin, about 50% of these patients came down with low hemoglobin, because, as I said, 50% came down with intra-abdominal bleed. ESR and CRP elevated in about 1/3 and 2/3 of the patients. Diagnostic images that used in the diagnosis, actually we see more of CT angiogram, again, used more than catheter-based or laparotomy or MRA or ultrasound. And most arteries that involved, actually consistent with the series that was published at Mayo too, SMA was actually the most commonly affected artery, followed by hepatic and celiac. and then renals and cerebrovascular. As a matter of fact, I think I need to emphasize the fact that cerebrovascular involvement, about 14% of these patients had actual cerebrovascular involvement. And again, multiple vessel, even if they use different criteria, about 62% of these patients with SAM tend to have multiple vessel involvement, kind of proving that our criteria probably is kind of more consistent than others. So pathological finding, most commonly pathology that we found was aneurysms, followed by dissection, rupture, stenosis, occlusion. But again, I think it's very important to realize that about 15% of these patients right here also come down with string of beads. So that makes it very hard to differentiate between SAM and FMD. We'll talk about this in the coming slides. Pseudoaneurysms, about 11.9%. Wall thickening, about 8% as well, too. So this is kind of another way of showing the data. So SMA is the most commonly affected artery, followed by hepatic, celiac, renal, and you see that aneurysm is the most common pathology. So diagnostic criteria, so different authors use different diagnostic criteria, but CT images are really the key point of making the diagnosis. If you have histology, great, and actually only 44% of the authors use histology as the main criteria for diagnosis. Catheter-based angiogram, autopsy, you don't want to wait until you get to that level to make the diagnosis, I guess. So what we saw over years, that actually we see that over years that the CT angiogram images were used more commonly to kind of make the diagnosis of SAM than histology, as you see there. So you see histology going down and CT angiogram images going up. So coil embolization for management was the most common kind of modality that's used. Again, we see more endovascular actually approach to treat these patients than open surgery, 23%. Open arterial repairs, 20%. If you ask me, what do you mean by abdominal organ surgery? Splenectomy, one of them, right? You know, ileostomy and laparotomy are those kind of abdominal organ surgery. Conservative therapy, only 8%. So most of SAM patients going to require some sort of intervention, as you see from the slide here. So outcomes, the good news, contrast to the previous publication. If you look at the previous publication before our paper, actually you see mortality reaching up to 50%. Here we were able to prove that, you know, with good medical approach and interventional approach, you can get up to 93% of survival rate. And as a matter of fact, symptom improvement, about 90% of these patients had symptom improvement. Imaging improvement, about 66%. Unchanged, about 17%. And so I think, you know, these patients, for the most part, got better symptomatically and imaging-wise. So the kind of most important kind of part of this talk probably is to kind of how do you differentiate between SAM and FMD, right? So SAM, presenting age is about 50 to 60, but FMD 40 to 50. Kind of more commonly in males for SAM, and as you know, 80%, 90% of FMD seen in females. Usually with SAM, it's more kind of acute presentation, right? More dramatic presentation with abdominal pain, bleed, right? We saw 50% of these patients presented with abdominal bleed. And with FMD, it's kind of maybe uncontrolled hypertension. Sometimes the patient comes with the renal stone, you find those bleeding appearance. So mostly these patients are asymptomatic for the most part. So the most artery that is involved in SAM is superior mesenteric artery. For FMD, it's mostly renals, about actually cerebrovascular, 73 to 80% of cerebrovascular involvement in FMD. When we used to kind of we used to think that most of renal arteries, but there is more cerebrovascular involvement in FMD than renals. And actually, you see SAM here, 13% of these patients can present with cerebrovascular involvement. So aneurysm is the most commonly found pathology with SAM, although beading is actually most commonly seen in an FMD, but you see different pathologies listed for you there. This is a CT angiogram, angiographic images of patients of ours actually here. So this is SAM. You see actually focal stenosis because of intramural hematoma and dissection of the right anterior carotid artery. You see irregularity, subtle irregularity of the anterior carotid artery here, but here you see more of beading appearance of the anterior carotid artery with FMD. If you can get histopathology, that would be great. So that would show vascular degeneration the medial layer for SAM, and you see fibrous changes in fibromuscular dysplasia if you can get to the histology. Coming to the end of our talk, so the summary, 143 patients, median age 55, comorbidities, again, hypertension, tobacco abuse. Most commonly symptom was abdominal pain, but again, around 50% of these patients came down with abdominal, intra-abdominal bleed, because about 50% of these patients came with the arterial rupture. Most commonly involved artery is SMA. Pathologies, the most common pathology that we saw was aneurysm followed by dissection. Again, diagnostic criteria, we see more usage of CT angiographic images than catheter-based or histology. And I think it's very important if you can get the genetic testing and pathology, especially in patients with multiple vessel involvement with beading appearance, to differentiate between FMD and SAM. We see more for intervention. We see more interventional procedure endovascular approach than open approach for the management. We also saw patients receive conservative therapy. So in the medical management, most patients receive antihypertensive for medical management. Some patients receive anticoagulation. If you have an arterial dissection without end organ infarct, there is really no point of giving anticoagulation. Antiplatelet therapy should be fine. The good news, about 90% of these patients had symptom improvement, 97% survival rate, and 66% of these patients showed imaging improvement following the initial presentation. So what is our approach here? And I think it's very important to realize we have a great team of vascular physicians here, vascular medicine, vascular surgery. I'm very proud to have a great team that I work with on a daily basis. Interventional radiology, I know that Dr. Schumacher had to leave because they have their own meeting on Monday morning. And general surgeons have been very helpful in managing these patients. I think it's key is careful history and physical exam, and also initial labs. We do CBC, CMP, LFTs, lipase amylase to rule out more common diagnosis than vasculopathies. And then we start with CT angiogram. I favor CT angiogram for the reasons that I already presented over MRA. And then we exclude common diagnosis. Okay. And then if there is some kind of concern about vasculopathies, we checked, again, ESR and CRP. Now there's a question mark about these, but we do ANCA to rule out vasculitis, ANCA-related vasculitis. If we can get tissue biopsy and genetic testing, that would be great. And I think, we have nailed it down in terms of diagnostic criteria that we use here, very consistent with other major centers. How do we follow up these patients? Most of these patients come back to see me in the clinic in 30 days, then 3 months, then 6 months, and 12 months. Now, if the patient has vascular Ehlers-Danlos with multiple vasculopathies, those patients really become friends. So, so they come back and forth to see us based on the pathology. If I know what the pathology is and I know the diagnosis, not always I use CT angiogram because of the radiation, right, contrast. So we try to use MR angiogram as well, too. So this is kind of algorithmic protocol for workup for these patients that we publish as well, too. And it's actually the most detailed algorithm that's out there to kind of address these vasculopathies. Last slide, I believe, here. So non-atherosclerotic abdominal vasculopathies are very rare, but could be life-threatening. There's really no consensus in some diagnostic criteria, especially SAM. There are different authors use different criteria. CT angiogram has become the modality of choice. ESR and CRP are elevated in most pathologies, and so their role is questionable in making the diagnosis. The role of genetic testing and pathology, I think they are very important if you can get them, especially in patients with multiple pathologies. So also, most patients received conservative therapy. Endovascular therapy has been more frequently used. As you see from our series, most patients have symptomatic improvement. Survival rate is great. Some patients had improved on their images, but some patients, they have aneurysms or bleeding. They are not going to have improvement. Multidisciplinary approach is the key. Actually, as you see, there is more research probably is needed to kind of close the gaps in terms of differential diagnosis. This is the sunset in Gaza Strip. I was there actually doing a medical mission this summer. I really got impressed, as much as I got impressed with the vasculopathies, I got impressed by the sunset there. And I'd like to thank all of you, and I'd like to thank my team here, Vascular Surgery, and I think special thanks. There are a lot of people who got involved. Actually, Dr. Thaler was actually part of the project. But the people that really did a lot of work, Sydney Olson, Jonathan Hyde, and Dawn Witt, I know that she's probably listening to the talk on web. Russ, thank you so much for the help that you provided, the interns and myself, to get this hard work completed. And thank you so much, and I appreciate your attendance. And any question? Thank you. Yes, then we'll get Jason.
Great talk. You know, as cardiologists, we see these syndromes rarely, and it's terrific to have a review and have your expertise here as a part of the foundation.
Thank you.
My question on your larger series, you said that surgical success was low. Can I misinterpret that? Can you talk more about that?
Yeah, so the problem with these, because these patients come down with significant kind of intra-abdominal bleed, and it also it depends on this kind of definition that we use for surgical success. So we use actually that complete resolution of the arterial pathology. So if the patient has kind of dissection or arterial rupture, usually you address the problem. But if there's a dissection, you know, sometimes you continue to have that dissection. Even though if you do colembolization, you still see some sort of dissection in another vessel. That's why that's good, our kind of finding. But most patients that if they came down with an intra-abdominal bleed, right, or hematoma, these patients actually showed improvement. Yeah. Jason, sorry.
Great talk.
Yeah, thanks.
So two questions, and one's, is there more vascular pathology, and the second one is there less? So with FMD patients, should we be scanning their brain for aneurysms? And then with celiac artery compression, do you feel like the compression of the artery is truly what's causing the patient's pain, or is this a surrogate marker for compression of the celiac plexus and it's really a nerve problem?
Yes, so these are two very important questions. So for FMD now, the current consensus, actually recent publication from the international consensus on FMD, that actually do recommend scanning the neck and brain on all patients. You really have to look to you know, for other pathologies, especially, as I said, cerebrovascular involvement is the most commonly kind of vessels that are involved in FMD. So true, yes, we have to scan. I do that. Check a CT angiogram of neck and brain. If you want to do MRI, that's fine too. So in terms of the celiac artery compression, absolutely. So some people actually don't believe that median arcuate ligament syndrome exists because a lot of people tend to have that compression. But even if you, as we know, if you even include the whole celiac artery, right, over time, you shouldn't get really symptoms. That's why people think it's a neurogenic kind of syndrome rather than arterial, because there are a lot of splanchnic nerves around the celiac artery. So if you compress over that artery, there are these splanchnic nerves really get irritated, and patients get really chronic pain from that compression over the nerves rather than just the artery. So that's why to kind of predict the success of the management of these patients, we tend to do ganglion block, and we did this with a few cases with Dr. Titus, who really did a great work on median arcuate ligament syndrome. And so we do ganglion block. If these patients have some relief of their symptoms, that's a good sign that they will actually improve with median arcuate release. So, yeah. All right. I think it's 8 o'clock. But if you have any question, please ask. Thank you so much. Appreciate it. Thank you.
I gotta go and ask Dr. Titus if he can send all of our media.